everybody, and welcome to the third of our International Health Workforce Collaborative panels to be hosted by our US colleagues. My name is Ivy Bourgeot. I'm with the Canadian Health Workforce Network, and I'm coming to you from Ottawa, the unceded, unsurrendered territory of the Algonquin and Anishinaabe First Nations people, to whom I pay respect. So I'm going to pass over to our moderator for this session, David Armstrong. Please go ahead.
Oh, thanks, Ivy. Once more, my name's David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center, for those of you who don't already know me. And the TA Center, we're located at the University of Albany School of Public Health in New York State. With that said, today's event features experts from 4 U.S. Health Workforce Research Centers located in the U.S., and they're going to be discussing some of their research on COVID-19 impacts on the U.S. health workforce. With that said, we have a lot to cover today, so I think we'll go ahead and get started. But first, let me introduce our speakers. Today, we have Bianca Frogner, an associate professor in the Department of Family Medicine, also the director of the Center for Health Workforce Studies at the University of Washington School of Medicine. Next up, we have Susan Chapman, the deputy director of the Health Workforce Research Center on Long-Term Care. And she's also a professor at the School of Nursing, Department of Social and Behavioral Sciences at the University of California, San Francisco. Also joining us is Brianna Lombardi, an assistant professor in the Department of Family Medicine and the deputy director for the Carolina Health Workforce Research Center at the Cecil G. Sheps Center for Health Services Research. And finally, also from the School of Public Health at the University of Albany and New York State, we have Jean Moore, the director of the New York Center for Health Workforce Studies. So that's our lineup today, and we have a lot to cover. So Bianca, how about you kick us off?
Thank you so much, David, and for those introductions. And it's so wonderful to be here today and see some familiar names and faces. And I'm sorry we're not here in person, but it's always great to have another forum like this to be able to connect again internationally. So I'm going to present some work that has actually recently been published, but I am hoping will still help set the stage a little bit about what's happening here in the United States. I have this work conducted in collaboration with a colleague of mine at University of Minnesota, Jeanette Dill. She's a professor there in the School of Public Health. And this work that I'm presenting today was supported through the Health Resources and Services Administration, which funds many of our health workforce research centers around the country. And here at University of Washington, we have 2 of these grants, and this work was conducted under our Allied Health Workforce Portfolio. And just here at the bottom of the slide, you do have some links here to the actual publication from which the work today is being presented, as well as a podcast that accompanied this, and all of which you can access with that QR code at the bottom. And I'm happy to make the slides available later if anyone is interested in getting these details afterwards. So I'm going to talk a bit about turnover in the United States during the pandemic and comparing it a bit with what was happening pre-pandemic. And the motivation of this study is that we knew that in the healthcare industry in the United States at the peak of the first peak of the pandemic, since there have been multiple peaks of the pandemic over time, is that healthcare lost about 1.4 million jobs. While many of those jobs returned by late summer and fall of 2020, as the first wave kind of found an ebb and flow, we didn't know a lot about kind of the details on a whole of who was really losing their jobs in healthcare. There were reports and studies coming out giving pieces of the information, and people in the field were definitely reflecting this in their comments, which are that we saw the nursing and residential care sector, or the long-term care sector, suffering quite a bit in terms of job loss. We know that many healthcare support occupations, such as home health aides and nursing aides, were also seeing quite a bit of job loss during the pandemic. And we also have heard that female healthcare workers, especially those with children, much like what was happening throughout the rest of the economy, were also struggling with job loss. Now, many of the reports that were available in the United States around job loss in healthcare were focused on total number of available jobs, or how many jobs were being filled, or how many people were employed. But we didn't have a lot of detail on who was actually leaving their jobs in a state of unemployment or exiting the labor force. And I think there's just a slight nuance there that's important to pay attention to, as when people leave their job, they're usually leaving in a state of either they're searching for a job or they're exiting the labor force altogether. So we were just trying to unpack that a little bit more. And there's a lot of detail in the study, and I'm just going to highlight a few key findings. But before I do that, I just want to give you a little sense of where our data are coming from. We're using the current population survey, which is a household survey conducted by the Bureau of Labor Statistics out of the Department of Labor. And we used the monthly sample between January of 2019, so taking about a full year of information before the pandemic began, and up until the most recent time we had available at the time, which was October of 2021. And what's great about this data set is it allows you to follow the same individual over time. It's a complex sampling frame. I won't go into it. Happy to answer questions about it. And we focused on those who said that they started working in healthcare and then in 1 month, and then in the subsequent month, they reported being unemployed or being out of the labor force. And we divided up our time period into 3 periods. One is that a year or so of the pre-pandemic period, just to kind of level set us where we were. And then we looked at about the first 9 months of the pandemic, and then followed on with a second period of the pandemic. And I'm going to show us a few slides in terms of how we broke down the turnover rates. And turnover here is defined by those who were working in healthcare 1 month and left the following month. And this is combining those who left in a state of unemployment or leaving the labor force altogether. And I think it's worth noting in this slide here that there's this kind of big bump that we saw in ambulatory care, where there was a large amount of turnover that happened in the first period of time. But by the end of the period that we were looking at, they basically returned back to almost where they were at the beginning of the pandemic. Hospitals also saw a similar pattern, except for a little bit less severe in that first period of the pandemic. But most concerning is the yellow line here, which is showing that long-term care saw a steady increase in turnover rates throughout the entire period, starting from a place where the turnover was highest even before the pandemic even began. Looking at turnover rates by occupation, what we see here is the really wide variation in turnover rates by occupation. And these are just a select number of occupations. There's a few more that are not presented here on the slide. But generally, what we saw were those aides and assistants, so your medical assistants, your nursing assistants, they really were experiencing the highest turnover rates, sometimes 2 to 3 times higher than physicians. And it's worth noting this because physicians and nurses in particular have been the highlight of many of our media stories here as those who have been experiencing a lot of turnover, but not as much story about the aides and assistants and the persistent level of turnover they had been experiencing. Now, the light blue line at the very bottom are the physicians, and it was interesting to us that turnover continued to go up throughout the COVID period, and they're the only occupational group to be doing so. So it is somewhat consistent with what we're hearing about burnout, also about among physicians. And another trend that was a little surprising to us was that for nurses, there was a bump up in the turnover in that first period of COVID, but by the end of the period that we looked at, they returned back to normal. Then we looked at turnover rates by race and ethnicity. And you'll note that everyone kind of followed a similar pattern of experiencing the most amount of turnover in that first period of the pandemic, mostly kind of returning back or getting a little bit better by the second period of the COVID pandemic. However, the orange and the gray lines kind of in the middle there are Black and Latino workers. And what is concerning there is that while there is some return in terms of the turnover rates back to closer to where we were pre-pandemic, they are the groups that are experiencing the slower recovery rates in turnover. And so that's something worth monitoring over time. Not only that, again, pre-pandemic, several of our non-white groups are experiencing higher levels of turnover even before the pandemic, which seems to be persisting here by the end of the pandemic. And I really don't mean end of the pandemic, but whatever phase we are at the moment. And then lastly, the set of turnover rates that we looked at was by gender and parenthood status, meaning having a child, a young child under 5, which we understood to be a group that was experiencing particularly high levels of turnover during the pandemic based on what we were reading. And again, here you see that women throughout the pandemic have been experiencing higher levels of turnover rates that compared to men. And then having children for both men and women tend to have higher turnover rates throughout the pandemic. And I think it is again worth noting that again, before the pandemic even began, women were having higher levels of turnover, as well as those with children have also been experiencing high levels of turnover. And those with children are experiencing slower recovery in this post-pandemic period. So in summary, although throughout this period, we did not actually look at those who were entering during this time, we only really looked at those who left. I do think it's still worth considering the fact that leaver rates are remaining higher than the pre-pandemic employment periods. While generally it does seem like people are on a rate of recovery, it is concerning that leaver rates were still relatively high, almost a year and a half, 2 years after the start of the pandemic. And physicians were the only occupational groups to see an increasing leaver rate, and that's something worth monitoring, given that there has been a lot of discussion about burnout in that group, and the numbers here do seem to suggest that. Now, that's not to say that the other groups are also potentially experiencing burnout and may also see an increasing burnout leaver rates over time, because keep in mind, we only look through October 2021, and these rates could continue to increase as time is going on. And long-term care, and those especially in aid and assistant jobs where there's a lot of overlap between those two, are clearly struggling to recover and have been struggling with retention really throughout time, even before COVID. And workers of color, and as well as women and those with children, are continuing to leave at this high rate. And again, there's a lot of intersection here with long-term care and assistant and aid jobs. So in conclusion, the pre-pandemic period, we really did see quite a bit of turnover among our long-term care workers, our women in healthcare, and our workers of color. And we need to really think about what might be driving this trend even before the pandemic, because these things were just exacerbated during the pandemic. And these are workers who were very low paid and often without very many benefits. So in many times, people were making very difficult decisions about staying in their jobs versus taking care of their family members or children at home. And with unstable schooling, and even with that recovering in this latter period of the pandemic, we're still seeing the struggle for people to stay in their jobs. And so we do think that there's more work that we need to do to keep monitoring the health workforce and turnover in this area. So I'll stop there. Thank you so much.
All right, thanks, Bianca. Susan?
Hi, everyone. Let me just try to share my screen here. Can you all see that? Can you see my screen?
Yes, we can see it. Thank you.
Okay, great. Sorry, I was waiting to make sure. Good morning, everyone, and thank you for joining us. I'm going to do this a little bit differently. I'm going to talk about a body of work that we did during the pandemic related to workforce, as having a workforce center and another research center focused on workforce, but not HRSA supported. We were called upon very early to join in the workforce discussion. I'm sure all the centers were doing this, and it presents a number of challenges. So I'm going to talk about that a bit, and then a couple of specific projects we did. So, and I also forgot that I did these late, so I forgot to add our disclosure statement, but we are also a HRSA funded workforce center on long-term care. So who called upon the centers and what did they want? This was our Health Workforce Research Center on long-term care, but also our Health Force Center, which is another workforce center at UCSF. A number of the same faculty, but not focused on long-term care, and also does training and research. So we were both called upon to address workforce quickly and early in the pandemic. So that included the Governor's Office of Emergency Response, the Department of Public Health. Private foundations were jumping into this and asking what they could do to help with workforce planning. And then in terms of HRSA and the National Centers for Workforce, we were asked to offer up some ideas about what we could do for COVID projects. So we did some very specific COVID, what we call rapid response projects. And we could offer up suggestions and then got feedback about what to pursue. So the big questions were about how do we surge staff for these for this pandemic in hospitals and outside of hospitals, which I'll talk about in a minute. And then how quickly could we respond? And again, what kind of short workforce project for our approach plan, it was very challenging. We're used to decisions. So we needed to find the right term of experts in terms of various staffing regulations in the state. I'm sorry if my internet is unstable, I'll go off camera. Is it okay for everyone? Okay, good. It happens to me every time I get on a call. So, who can we consult? The idea here was how much can we bend regulations? How much can we bend existing regulations and still safely provide care? Now, the governor was involved in this in our state, and I think many states, in issuing these executive orders that address some of our constraints on practice, such as scope of practice regulations, and nurse in our state in particular, nursing ratios, which we have in hospitals. So how could we do this with our existing regulations, and what could we ease up? What could we allow waivers for and not allow waivers for? So we also looked at what other states were doing and who was setting standards. We looked at, CDC, offices of emergency responses, et cetera. What have we done in the past? And we could draw on, particularly in California, some of our rapid responses for floods and fires in particular. And then we had to make our best guesses with caveats. This is how we think we can look at regulations and waivers and still staff safely, but there are a number of caveats to this. So we had to talk about our caveats as well. So this is an example, and I don't expect you to be able to read this. I'll send the slides later, but I think what's important here is our sort of disclaimers here at the top. This is our rapid response, and it's not supported by, it's not reflecting the opinions of the university. We used our best available literature and crowdsourced information. Again, this is not, this isn't something you're going to find in the publications, right? So we did some benchmarking, and then we did a list, and this is only a partial list of what are our baseline staffing. And as you can see in physicians, 1 to 7 or 1 to 10, how much could we stretch that? Well, maybe 1 to 8, 1 to 10. And then what we used for data, looking down at the advanced practice nurses. And again, we have a whole table for all professions. We didn't think we could necessarily, we could go to 1 to 7, but not more. Where this becomes critical, I think, is when we look at the hospitals, nursing ratios, and also some of the CNAs and HHAs in home care nursing homes. So we also made a number of recommendations, and these were on actually the Health Force Center website. These are kind of the highlights. This was probably about a 15-page report. Again, our opinions and our best guesses at things. And some things about what we could do. These won't be surprising to any of you in terms of course, this is what you need to do when you're trying to do surge staffing and cover workforce when we're in the midst of this pandemic. So obviously expanding scope of practice is really a key thing. And what this means, particularly in our state, was looking at some of the scope of practice restrictions and easing them up a bit. Expedited licensing for eligible professionals. I don't know about other states, but our Board of Nursing has quite a backlog of licensure licensure approvals that they're sitting there. So we have nurses ready to work, but they don't have a license yet. So how can we expedite the licenses that are sitting in that inbox? Deploying students. We are a nursing school, and we have RN training and as well as advanced practice nurse training. How could we use those students if they were willing to to work in a surge capacity, and that depended a lot on their personal circumstances. So how could we best use students to expand the health workforce, and what could they do in terms of their skills and regulations about what they could do at various points of their training? Also activating the National Guard and looking at what we've learned from military expertise in this area, while at the same time ensuring safe provision of care. We thought it would be very important to assure that there were medical interpretation services available, because a lot of people coming in the door may not be speaking English. And then this is something we were asked to evaluate, and I don't remember if it was HRSA or one of the state people. There was a ready CNA online training that was very rapid, much less than the usual number of hours for CNA training. CNA is certified nurse assistant, and these are the mainstay of nursing aides in nursing homes. So we were asked, is this a quality training? Is it feasible to use this? Can we train people in that few hours? So we gave it a look over in our best guesses. And this is the website where most of this information is. So in terms of the HRSA projects, we did several, and I'm going to talk about two. These are what we chose to do, looking at alternative care settings, which I'll talk about. We also looked at the utilization of community paramedics during a pandemic and things that they could do, home visits, eventually helping with vaccinations, characteristics of, I'll tell you why we did that in a minute. And then just to say, COVID is, as we said, far from over, but it's also far from over in terms of our research projects, even ongoing. We're looking at COVID impacts on staff, on workforce, as a little bit of and it impacts all of our current projects. So alternative care settings, you probably all heard of these and many have used them. Where do we put people when the hospitals are full? Where do we put people who might be infected or don't know, or just to get them off the street? So we did a number of looking around the country. What were people doing and where were they? As we probably know about some of the tents and tent cities and Central Park and New York, et cetera. But we chose a few. We chose one local and then one in Boston. The other thing, this was totally convenient sample in who we could get to talk to us. So this is the Boston Field Hospital, which is in an old convention center in Boston. And it was created by Boston Hope. So we got some information from them. I don't know if you could see this very well, but those are big sort of bed areas with partitions with curtains. And then we looked at a hotel, not being used hotel in Oakland, which was again where we could house folks. So what did we learn from this? These sites were used to relieve the capacity constraints of hospitals. They were often focused on vulnerable and underserved populations, the unhoused and people with disabilities who needed a place to stay safely while they were being evaluated for COVID risk or quarantining, and also to get folks off the street to reduce their exposure. So this was also about how do you scale up and diverting a workforce? How do you set up one of these centers? What do you need in terms of staffing and teams, and who's essential and what do they do? So there's a lot of data on this, and people were, winging it and also doing it a little bit differently everywhere. But some of the keys, I think, to implementation are to have disaster planning experts. They know this stuff, and so we included them. They're not often at the table for workforce planning, but they needed to be. Looking at workforce role flexibility, obviously a lot of interagency organization cooperation, which in particular, in states with a lot of different agencies involved, doing this in a cooperative effort was important. Sharing protocols with each other so each center didn't have to reinvent the wheel. And then where were there available and temporary large spaces that could be set up quickly and also taken down when needed. So characteristics of multiple job holders in long-term care needs a little bit of explanation. Why did this matter during COVID? And this dovetails a lot with what Bianca covered in her presentation. Direct care workers, nursing home aides, home care aides are low paid, few sick benefits, so they need to keep working. They couldn't stay home. They certainly couldn't work in remotely. This was in-person work, and they continued to need to work in person. Home care aides worked in order to get full-time work and some sort of mini sustainable wage. So they're going from home to home. In some cases, there was more work. In some cases, there was less work here when clients, if they could, didn't want their home care worker to come. And then working in more than one nursing home job is also common, and turnover is common. So there's a lot of moving around in nursing home workers as well. In addition, some nursing homes just closing. So where do you redeploy those staff, and how exposed are those staff? And then obviously these workers are at risk for getting sick with COVID and all that implies in terms of themselves and their family, and also at risk for the spread of COVID, particularly to frail elderly folks. So I'm going to just go over quickly our methods, and Bianca talked a little bit about the current population survey. That's what we used as well. We had used 10 years of pooled data. So this is pre-pandemic actually. So, because of this survey, we didn't have pandemic information at that point. And then the questions that we looked at is, did you have more than one job, and how many jobs did you have? So really briefly, what did we find? I think here are RNs, and we had to do a lot of grouping because of sample sizes. So RNs and licensed practical nurses in long-term care settings. Licensed practical nurses for us are about the 1 year, 18-month nurses, not registered nurses, but can do most of what registered nurses can do. And then obviously in the PCAs are personal care aides. So we compared those to in some ways we compared them to non-long-term care settings. So I think the finding here that's interesting is the PCAs in the long-term care settings. About 7.1% had multiple jobs compared to 4.4% in the non-long-term care settings. So this is a workforce that has multiple jobs, continues to have multiple jobs because of economic issues, and therefore we're at risk for spreading COVID. And so how did we address those issues, which I'm not going to have time to talk about. But anyway, that's all I have to say. And here is our health workforce website and the Health Force Center. I know we've got too many words here that have health workforce and health force, but that was on a previous slide. So thank you very much.
Well, that Health Force Center, that was always confusing to me.
Yes.
Thanks, Susan. Next up, we have Brianna. And for those of you in the audience, keep the chat going. It's very engaging.
Yeah, and I'm trying to find my stop share. Here we go. Got it. Okay, thank you.
All right. Well, thank you so much. As David mentioned, I'm Brianna Lombardi. I'm coming from the Carolina Health Workforce Research Center. I'm the deputy director at that HRSA-funded center. I'll put on our funding statement. And similarly to Susan, we'll be talking about 4 studies that we completed during the pandemic that were funded by HRSA to really understand the experiences of the health workforce during this uncertain time. The first study I'll talk to you about was conducted by Dr. Don Pathman, looking at the experiences of safety net practice clinicians during the COVID-19 pandemic. For the folks who are here that are outside of the United States, we sampled the clinicians from the National Health Service Corps, which is a federally funded loan repayment program to both address student loans of our health workforce, but also to identify ways to staff some of the higher need health systems and health clinics within the United States. And this survey was conducted in late 2020 and surveyed about 2,000 National Health Service Corps clinicians in 20 states, which was a response rate of about 44%. And you can see, and this has been documented within the literature across the United States, but certainly internationally as well, is just this high rate of self-reported burnout, and also, beyond, the feelings of burnout, but experiencing feelings of depression, hopelessness, and the toll on emotional well-being. This study looked at the experiences across provider types, so both looking at primary care providers, but also dental health and behavioral health providers. And there was some significant differences across these clinician groups, but overwhelmingly the rate of self-reported burnout was high. So In total, more than 75% of the sample had clinically significant symptoms of burnout. And what's interesting is that although dental health was a bit lower, these were for folks who had higher rates of furloughing and position changes during the pandemic. But, thinking about burnout and the health workforce is not new to the COVID-19 pandemic, although certainly this was an additional global stressor. And so even prior to the pandemic, the Carolina Health Workforce Research Center was really interested in studying some of these structural issues related to physician burnout. And this was also drawn from the 2019 United States National Academy of Science, Engineering, and Medicine report, really thinking about what is the socio-ecological model of physician well-being? How is it beyond just the individual providers' characteristics that are really impacting physician burnout? And so this study was conducted by Dr. Tanya Jenkins, who's a sociologist, and did a clinic-based ethnography of pediatricians trainees at an academic primary care pediatric clinic. And Dr. Jenkins was within the clinic for about 6 months, both observing and also interviewing, and interviewed more than 65 of the pediatricians, trainees, and medical students, and really asked them about their experiences and drew away some and helped further kind of flesh out our understanding of how institutional, professional, and societal factors were driving the burnout that they were describing. And when we think about institutional factors, particularly during the pandemic, was this institutional inflexibility of the physician's schedule. So the amount of hours that they need to work. And then certainly, as many of you know who have young kids, a lot of school closures, a lot of daycare disruptions, and how that inflexibility within the job was one example of institutional stressors that were being described. And that is also within the context of this professional structure, professional influences. Pediatricians are known to put their patients and families first. And certainly even some of the messages they were hearing was, you put on your patient's life mask before you put on your own. So this professional expectation. And then finally, these broader societal and factors that are going on. COVID-19 was also going on at the same time as a renewed emphasis of considering how racism is impacting the health and well-being of the United States, and just this overarching feeling of how there are deep social inequalities that are impacting their patients that they are not able to address, and the weight of that. And so really thinking beyond just how these individual larger factors, but how these are compounding on each other. And what institutions might do in order to address burnout when it's across multiple factors. But we were also interested in looking at not just physicians, but within the spectrum of healthcare providers or healthcare workforce, looking at what we call low-wage workers, or particularly probably be called underpaid workforce. And these are the health workforce that are working in hospitals, in environmental services. These are the folks who are working to feed the hospital system, or clean the rooms, or move patients to different areas. And we were really interested in understanding their experiences during the COVID-19 pandemic. And so this was a qualitative study of 20 environmental services and other underpaid health workforces in the hospitals in North Carolina, Colorado, and I think New York. I forget this third state, my apologies. And really, this has a lot of text on the screen, but we wanted to show their voices to really hear, for you all to be able to read and hear what this workforce was really describing. And many of the sources of burnout are not unique to what other health workforce disciplines were experiencing. The pressures of having changing duties and being understaffed. So folks really describing, their role was to, be a cook, but all of a sudden they were a cook and a cashier, and they were the cleaning. And so just kind of expanded responsibilities. And similarly, that they had a fear of potentially contracting COVID-19 and the risk of endangering themselves and their loved ones. Although they are not the ones maybe providing direct care, they were in the hospitals and they were in contact with folks. And this person said, I do have a minor child with a pre-existing condition, so I have to be very careful when I come home. It's not just come on and hug on me when I get home. It's completely different. And that makes me more careful at work, so I don't bring stuff home. And relatedly, with being at this height of exposure, just the desire for recognition about the risks that they were also facing and the importance of their jobs. And some of the participants also really described there was a lack of clarity around COVID-19 benefits for their positions. And there was some feelings that although there was clarity for the COVID-19 benefits for some of the other health workforce positions within their hospital system, that it was unclear if they were able to receive those same benefits, and that lack of perceived unequal distribution was a source of burnout. But also the low-wage workers that we talked with all really talked about a sense of pride in their work and things that really were protecting them or keeping them going. And we spoke with these workers about a year into the pandemic. And so these were folks who had stayed in the workforce, who had stayed in the hospital systems, and really talking about things that protected them. One of them was some of them did really say there was this designated time off for them if they tested positive for COVID-19 as a benefit that they appreciated and received. They talked about that there was organizational efforts to provide mental health support even to this workforce, which was important. And then finally, that there was this sense of self-coping and some of this internal resilience that they were describing. This person described having pride in what they do and this acknowledging that maybe other people might not understand that they take pride, but what they do is important and that they make a difference. And I'll just wrap up that we did a scoping review really early on in the pandemic because we were interested in observing how health systems were responding, what interventions they were doing to protect and buffer the burnout that was quickly emerging due to the COVID-19 pandemic. So we did a scoping review of United States-based health system interventions, and we identified 20 articles, 85% which were from academic medical centers because they had academics like myself who were able to write these things up, I'm sure. And what we did was we extracted and coded the types of interventions that health systems were using. And we were actually really impressed with the broad swath of types of interventions. So doing some of the more traditional things that we would think about, which is, making sure folks have PPE, the appropriate PPE to do their job, but also we're being focused on enhanced communication, wellness initiatives, really beefing up mental health supports, both individually and within the context of a group or unit, but also trying to target some of the other things that were particularly unique to COVID-19, like providing meals or groceries so folks didn't have to go to get food or be exposed in the community, as well as parking vouchers so that they wouldn't have to take public transportation, which would increase their risk of exposing to COVID. And so really thinking about, although health systems were trying to find new ways to reach and address the stressors within their health workforce, that these are still pretty small when we think about the contracting circles that we saw within the socio-ecological model. So really thinking for the future how we're going to address some of those broader system factors as we come, as Bianca mentioned, we're not out of the pandemic, but wherever we are in the pandemic. And just wanted to point us back to our website. The Health Workforce Research Center put out some surge strategies as well, and we have all of our products up there. So thank you.
All right, thanks, Brianna. Next up, we have Jean Moore. And Jean, I'll go ahead and share your slides for you. And Jean's going to be discussing some of the work we've been doing at the Health Workforce Technical Assistance Center, which, as I mentioned, we're both located in New York at the New York Center for Health Workforce Studies. Jean?
Thank you, Dave. So I'm going to be presenting research conducted by IHWC. Next slide, please, Dave. And IHWC is funded under a cooperative agreement with HRSA. and provides technical assistance to states and organizations that engage in health workforce planning. And for those of you who aren't familiar with us, I invite you to check out our website. Next slide. So the Health Workforce Technical Assistance Center has been monitoring COVID-19 impacts on health professions education. We think it's a pretty important topic. We're not sure that a whole lot has been done with that. So I'm going to talk about some specific research we've done. So the Center for Health Workforce Studies has been conducting a survey of nursing deans of New York State's RN education programs, and we've been doing it since 2002. And we ask about things like number of applications, acceptances, graduates, perceptions of the job market. And similarly, the Health Workforce Information Center based in Utah has been conducting an RN education program survey since 2015. So we combined forces. We added a series of COVID-19 related questions to both surveys in 2020. And what I'd like to do is share with you some of the things we found from this survey. We had a response rate of 60% from the New York education programs, 40% from Utah. Next slide. So, the vast majority of nursing deans in both states reported pandemic-related disruptions in 2020. 91% of New York deans, 86% of Utah deans. Next, please. Fewer clinical training slots was the most frequently cited pandemic disruption. As many of you may know, when the pandemic hit in March, many facilities were unable to accommodate many students at all, and it was quite problematic. There were a couple of other interesting responses to pandemic disruptions that I want to point out. New York deans reported more students dropping out or taking leaves of absence, and Utah deans reported more faculty retirements. Next slide, please. Simulation was the most commonly used strategies to help students meet clinical training requirements. And I know in New York there was some concerted efforts to make sure that the use of simulation in this circumstance, was acceptable to the state education department who monitors nursing education, to the agencies that approve nursing education. So again, it was something that was done very consciously. Next slide, please. And on the topic of student attrition, the nursing deans reported a number of different reasons for it. Top among them, increased family commitments, personal health issues, which I think ties well with what we've heard already. Next slide, please. Another interesting point is that the deans reported little change in the number of applications they received, acceptances, and graduations in 2020 compared to 2019. Next slide. Deans in both states reported turning away qualified applicants from their programs. 60% of deans in Utah, 43% of deans in New York. And the most commonly cited reason was program admission caps. And I want to say this is not new. Qualified applicants get turned away a lot, and it just has to do with limitations to the number of students that can be accommodated. However, what is new is that about a quarter of the New York deans reported lack of clinical training sites as a reason for turning away qualified applicants, although that was not an issue in Utah. Next. The deans in both states generally agreed that there's greater demand for new graduates, that the job prospects for new RNs are very positive. Next slide, please. And interestingly, in New York, the majority of the deans reported hospitals as having the most jobs for new graduates, while Utah deans reported home care as the setting with most jobs for their graduates. Next slide, please. Some closing thoughts. RN education programs in New York and Utah encountered some similar pandemic-related issues. Major clinical disruptions resulted in a reduction in training slots, and using simulation helps students meet clinical training requirements. I want to point out that this is a double-edged sword. We've been doing some more recent research around new grads and their experiences in their first jobs. And there's some sense that perhaps there's a point at which there's too much simulation, and nursing students who complete their training come to their first job with not a lot of hands-on clinical experience. So I think that is something that needs to be looked at more closely. In New York, there are a number of programs springing up to support nurse residencies for new grads. And I was on a call with a number of CNOs yesterday who feel that it's an absolutely critical strategy to retain these new nurses. Again, more demand for new graduates. I think that right now, what we're seeing in New York is that providers in all settings are experiencing some pretty serious shortages of nurses and have difficulty recruiting them and retaining them. So certainly there'll be many opportunities for new grads. But I think it speaks to the need to monitor COVID impacts on health professions education in the longer term. So that's my presentation. Next slide, Dave. Thanks. This acknowledges that the funding for this work was provided by HRSA. Thank you.
All right, thank you, Jean. And now I believe we can kind of start the more formal Q&A session, albeit there has definitely been an active chat. Jean, real quick question. This is from the audience, and I'm guessing you can't really, I'm not sure if you can see the actual conversation going on in the chat. Can you talk a little bit about program admission caps? What do they do to us? At limitations on faculty? I mean, what's behind program admission caps?
So when you think about nursing education programs, you know, who runs them, et cetera, and, you know, in a state like New York, they're mostly publicly sponsored. You've got City University of New York, you've got State University of New York, you have associate degree programs that, you know, are kind of the backbone of nursing education upstate. Bottom line is that the tuition charged for these programs doesn't even come close to the cost of providing a clinical education. So the issue of program caps has been around for a long time. And, you know, whenever in the past, whenever we've said to nursing education programs, hey, what would it take for you to expand the capacity of your program? And again, the resources they would need to add more faculty and I will also say that even prior to the pandemic, competition for clinical training sites has heated up, and it's become increasingly difficult for nursing programs to secure the clinical training sites they need for their students. And, you know, I think that there's always been an issue about recruiting and retaining qualified faculty, and frankly, I think that's worsened with the pandemic. So again, the program caps issue is an interesting one, and again, I think if there was political will to try to expand capacity of nursing education programs, that these are some of the issues that would be on the table.
All right, thanks, Jean. And another side note on that, to kind of give the audience, you know, a broader perspective. In New York, since 2002, privately funded nursing programs have nearly tripled. It's really the public funding ones which are, well, more restrained. That said, we have limited time left, so I kind of just want to throw a question out there to the entire panel to kind of get your reaction, and really this is for the audience too. And that is, COVID-19 is ongoing, and as researchers, we have 4 of the leading experts in the US country here on our panel today. What are the questions we should be asking? What are the burning questions? What should we be looking at? And this, of course, applies to other countries as well. So by all means, chime in the chat as well. So anyone want to start off with, by all means?
I'll try to take a stab at it. I saw Brianna also should definitely try to chime in here too. There's so many questions. I think one just related to the work that I presented earlier is this ongoing need to keep tracking kind of who is staying, who is coming to the health workforce, as well as who's leaving. But really, we need to dig more into the underlying question of why are they leaving, which we couldn't get into very well, and really parse out those who are experiencing the sense of burnout versus, you know, understanding the role of pay, all of which probably intersect in a lot of ways, but we don't have very good ways to track that nationally, and we do rely very much on qualitative work, which is important, but I think we need to also figure out how to embed some of these questions and to sort out what the role of COVID has been in this versus how much of this has just been long-lasting problems that have been happening. And so what I'm probably most fundamentally concerned about is this question of, did we learn anything from the COVID pandemic? Like what really changed from pre-pandemic times, and what will be sustained in those changes? I'd love to hear some more positive stories like that too, I guess. I'll turn it over to Brianna.
That sets it up. What I was thinking is what works, what did work. So a lot of health systems and states are trying strategies to address burnout and retention, but the evidence of what works. So you'll notably notice in that scoping review, we didn't say which of these were working. These were just folks describing what they were doing. So, you know, certainly understanding why folks are leaving the workforce, and also what can retain them, I think will be really important. And we know a lot less about what actually works to keep them. And like Bianca said, it's not just at the individual level, like the person is resilient or is, you know, accessing mental health supports, but what are the institutional structural factors that need to occur to keep folks in the workforce?
I was going to respond, not necessarily with what works in some research questions, but what are opportunities for policy change. And I think the debacle in our nursing homes and long-term care has really opened up maybe a short window of opportunity to do some real changes in nursing home structure. In California, we had about 8 nursing home reform bills following COVID and publications, which Charlene Harrington, my colleague, who is nursing homes #1 research enemy, published about the devastating results of nursing homes. So we've got bills in our legislature. We have President Biden talking about long-term care supports and services in the American Rescue Plan. So we all know it won't all happen, but there's some policy windows of opportunity here. A number of states changed their scope of practice regulations for advanced practice nurses. If you ease up on a regulation and you find, that's one thing that, we haven't studied sufficiently, but what happened with easing up these scope of practice regulations, what were some of the quality issues? So do you need to go back to more restrictive regulations after you find that nothing happened? So those are some of the things that we're thinking about.
Thanks, Susan.
I want to say that the changes that occurred through executive orders were pretty interesting, and workforce issues that folks had been trying to move forward for years and years, and then suddenly, boom, change in scope of practice, facilitated licensing. It's like, oh my God, and so they need to be evaluated. We do need to understand what happened. And, there are many who are saying, okay, well, let's go back to the way it was. Pandemic seems to be dying down. And I don't think that's the right way to look at it. I think it's, again, the question of, hey, what have we learned and what should we change? And to be honest, I think that the current workforce crisis creates an opportunity to look more closely at changes that maybe need to stay changed.
All right. Thank you, Jean. Well, we're right at the top of the hour. And so unless there's any other thoughts that you really feel like you need to express, I'll go ahead and turn the event back over to Ivy for some closing thoughts.
That is wonderful. Thank you so much. The chat has been incredibly active. And as you can see, there are many issues that resonate across our countries. And I've just made a suggestion that, in addition to do country-focused panels, it might be interesting to take particular themes and have each of the countries contribute to that, and to really build on this conversation that has emerged is what have we learned and what data do we have or don't have to address any of those questions. I will be in my envious state as a Canadian because we do not have any HRSA research funded centers. We don't have any federal government funded research centers. I wish we did, because I think that we would move the needle a little bit further. But beyond that, I just want to thank everybody for joining. Thank you so much to the presenters. Thank you, David, for moderating. And at 4 p.m., you'll hear from Canada. I'll be moderating with my colleagues, and I look forward to having you join us then. And this, as soon as Zoom processes this will be available to link out. We will also be posting it on our Canadian Health Workforce Network YouTube channel. So thanks, everybody, and have a great afternoon.
Thank you.